Good morning, good evening, good afternoon, depending on what part of the world you are in. I am your host today, Bianca Frogner. I'm the director of the Center for Health Workforce Studies at University of Washington in Seattle, Washington, and I'm a professor in the Department of Family Medicine. Well, welcome to the 2023 International Health Workforce Collaborative. I know some of you have already been participating in activities earlier today. Some of you, this may be your first session. Just briefly, the IHWC is a conference that brings together policymakers, academics, researchers, and practitioners from the United States, Canada, Australia, New Zealand, and the UK with responsibility for and interest in health workforce issues. And this year's theme is innovative approaches to common challenges. So on this day one, panel number 2, we will be hearing about interactive health workforce dashboards from 3 countries. I will be introducing each speaker as they come up. We have a representative from Canada, the US, and the UK. Each speaker will be speaking for about 15 minutes with a prepared presentation. We're going to attempt to have some audience participation at the end of each speaker's presentation, where we want to hear from you. What about their presentations you would like to see more in a live demonstration? So I'll give you some options for people to try to vote on. And then at the end, hopefully we should have some time for some Q&A with the audience. And please try to use the Q&A function, which we will monitor along the way. Also, I know folks might be in the room, so you could also you could probably come to a mic and speak, and here similarly online, I think there's a way for you to speak your questions. So with that, I do believe we have an in-person speaker probably ready to go, standing there with you. Steve Slade from Canada. He's the Director of Research at the College of Family Physicians of Canada. The title of his presentation, as you can see, is Medical Care in Canada, Getting More Out of Public Data to Address Real-World Questions. So with that, I'll ask Steve to go ahead and kick us off for today.
Thanks, Bianca. Thank you very much. And hello again, everyone. Looking forward to this session. I'm going to jump right in. So medical care in Canada, getting more out of the data that we have at hand for real world questions. So medical care, I want to start out by just saying this. I think it's an important point to make, that all healthcare matters. I want to be very clear on this. We're going to be looking at medical care data, but I want to just say that as we talk, this is an international health workforce collaborative. It is very much about the full spectrum of disciplines and types of work. And so, when we look at things like an aging population that wants care at home, when we look at counseling services that are provided through our employers and so on, when we look at, self-determined, holistic, and culturally safe care for Indigenous peoples, medicine plays little or no role in some of these areas, and so it's important to bear that in mind. A lot of the data that we have are, in a previous session, we talked about the 800-pound gorilla, physicians and nurses. And we have a lot of data in certain areas and less data in other areas. So I'm just very cognizant of the fact that I'm presenting data on medicine, which is important. I have to say it is critically important. And there's a lot of mileage we can get out of our data that we are not getting out of our data yet. And that's where my focus is on right now, is just acknowledging the importance of all healthcare, and the fact that we do have this data on medical care that we can be doing more with. The reason it's important, for instance, in Canada, family doctors are the regular care providers. We have a very large national surveys that tell us this, that family doctors are the regular care providers in Canada, and yet about 1 in 5 Canadians, 1 in 6 Canadians do not have a regular care provider, and the trend is not in a good direction in that regard. There are problems of access to that kind of primary care, medical care provided by family doctors. We are hearing in Canada, some of the biggest issues that we're facing right now is that ERs are being closed. People are getting picked up in ambulances, and they are arriving at the hospital and not being able to be seen, and they're having to go elsewhere. And that is about medical care. Surgical wait times have not gone away. They continue to be a problem in Canada. And this, again, it's a persistent problem, and it relates to medical care. And medical care costs. I mean, it's a big part of our health spending. And so if for no other reason than to look at sort of where we're spending our money, there's a need to look at medical care. So just a bit of some data context here. This is a breakdown of health spending in Canada based on our national health expenditures. I think we spend something in the order of $250 billion, approaching $300 billion a year for all forms of healthcare in Canada. In that wedge of pie, physicians, medical care accounts for about 13.6% of total health spending, second only to hospitals and tied with drugs. So in terms of context, what happens with medical care, what happens in terms of physician spending, it's a significant piece of information. It relates, medical care relates to some of these other areas. You know, hospitals and other institutions are largely there to enable and support the delivery of medical services. Physicians prescribe drugs. So what's going on in medicine, I think, matters in a number of ways. And so, you know, when we look at medical care in Canada, perhaps in other countries as well, there are new ways of remunerating medical care. There are new models of delivering medical services within countries. In Canada, about 70% of all medical services are remunerated through fee-for-service billing systems, and about a quarter, about 20% or so, a little over a quarter delivered through alternative payment programs. The reason I point this out is that fee-for-service systems, just by nature of the way that they work, they lend themselves to looking at what has been done with all of their imperfections. When you do a thing, you submit a claim for it, and that claim describes what is the thing that you did, you know. And so fee-for-service, is a significant way of remunerating medical care. When we look at the data in Canada, this is information published by the Canadian Institute for Health Information, 96% of physicians receive some measure of fee-for-service payment. Some, that's entirely the way they are remunerated for their services. Others are, receiving payment through blended alternative and fee-for-service payment systems. In Canada, this $22 billion, this wedge of the pie, is a significant chunk of money, and so when we're looking at medical care, there's a number of ways that you can do that. You can do surveys of physicians and ask them what they are doing. You can extract data from electronic medical records, and that's certainly something that happens in pockets and in different ways in Canada. But there is $22 billion of our total health spending that comes through these fee-for-service systems. So it's a significant potential way of looking at things. So there's public data that has promise. And I just want to describe what that is. So the tool, the innovation that we're going to look at for my section here is based on information published by the Canadian Institute for Health Information, using their national physician database. This national physician database is comprised based on data that's delivered to CIHI from provincial and territorial medical service plans on a quarterly basis, and which is linked to fee-for-service billings. It's pan-Canadian, this data. You can get it for, I believe at present, the only jurisdictions that are not submitting to CIHI are Nunavut and the Northwest Territories, but all other provinces and territories are providing data to CIHI. The data is broken down by 17 medical specialties. So for 17 medical groups, you can look at these data that are coming through. And I think one of the most important points that I hope will come through today is that you can look at this medical service data based on 103 clinical service areas. So How amazing would it be to have a quarter century of medical service data broken down by provinces for 17 medical specialties and describing over 100 different things that physicians do? I'm a bit of a data geek, and that excites me. The notion of being able to do that is a possibility. And so a lot of work goes into creating this NPDB data file. And we're going to take a look at some of the things that are in there, but more is needed. What you can get off of the internet right now is very basic information. And what this, the work that I've been doing is about how to take that further. So I want to take a quick look at what the data file is. I know this is a bit of an eye chart. Don't expect you to be able to read it, but it is the kernel of what CIHI provides publicly. You can download this. I didn't actually put the hyperlink here, but if you're interested, can give you the hyperlink, and you can go down. You can go and download this data yourself. So what you're seeing is a spreadsheet that for the first few columns, it's just describing a province, a territory, a specialty, and a medical service area. Medical services like psychotherapy, counseling, hospital inpatient assessment, surgical assistance, hips and knee surgeries, and so on. So you get a category that's broken down for a clinical area, for a province, and for a year, for a time period. And then you get a series of data on that. You get a head count, the number of physicians for this specialty, for this province, for this year, for this type of clinical service area that actually billed for that thing, the number of services that were done, the total payments that were paid for that thing, and the services per 100,000 population. That's what CIHI gives you right now. This is a massive file, if you can imagine, right? 25 years times 17 specialties times 103 clinical service areas, it becomes a much larger file than Excel can handle. So CIHI has to give this to you in 2 separate files, and they calculate subtotals, for all of Canada and for medical specialists and surgical specialists and so on. So it is an unwieldy big data file that cannot be put together in one data file. And so this is confounds your ability to analyze and look at it. But that is what it is. And this is where I have taken that data and tried to make it a little bit more useful from an analytical point of view. So a different data structure, delete the subtotals. When you port this data into something like an Excel spreadsheet that you can pivot, you don't need the subtotals. You can calculate those yourself in whatever, whether you're using SAS or Access or whatever. You can calculate certain things. Just that alone, removing the subtotals, allows you to have a file that covers the full time period, 1996 to 2021. It also, you can calculate, as I said, your subtotals for provinces and for Canada. And this restructuring of the data also allows you to move what is rows of data within the original worksheet, these subtotals, and use them as denominators for calculations that you're going to carry out later on to get new indicators, these new metrics. So the new metrics are things that you get, as we saw, you get a head count, the number of physicians that do a thing. But what you don't know is, well, for that specialty, for general surgeons or family physicians or anesthetists or whatever, what percentage of them do that thing? That's not something that's in the original data file. So there's a series of new metrics that, and we're going to take a look at them in a second here, that relate to providers of the service, the services themselves, a series of metrics that tell us a little bit more about those services, as well as the payments, the payment per service, and the services per population. And so we're going to take a look at some of the way that this data is being output. Just looking at my time here. So the new metrics, participation rates, things like What percentage of providers do this thing? And for all the providers that do a particular thing, whether it's putting casts on or doing pap smears or doing psychotherapy counseling, when I look at all of the physicians who do those things, what percent is done by family physicians or pediatricians or, psychiatrists and so on? So participation rates and looking at how a care area is split out across specialties, the share of services, when you look at services, what percentage of a service is done by general surgeons or family doctors or orthopedic surgeons and so on. So we have a series of new indicators. I don't want to belabor the point. We're going to take a look at some examples as we go through here, and I just want to give an opportunity for other presenters to get their piece done as well. So these new indicators allow us to explore questions that are closer to real world questions. If you're a planner or a researcher, then I think these are the kinds of questions that come to your mind. You don't really need to know what the head count of this is or the number of services of that, but you're more interested in things like, are family doctors narrowing their scope of practice? Can we look at participation rates to get at that? What percentage of family doctors do X, Y, and Z? Are we seeing increased medical service in wait time areas? Like we've agreed that we are going to tackle wait times in certain areas. And so what is the knock-on effect in terms of service delivery, the services per physician or surgeon that's doing these things? What does it cost when things switch? Actually, family doctors do many things and general surgeons do many things. So when things when medical service areas shift between specialties, what is the cost of that shifting? The fee schedules are unique to specialty groups, and a similar thing is paid one amount for one specialty group and another amount for another. So what is the impact of all of that? And then, where scopes of practice are changing, we can measure that. We're going to take a look at how we can measure some of the scope of practice stuff using this data. What are the implications of that in terms of potential service gaps? Does anybody pick up the slack? If family physicians move away from a clinical area, is someone picking that up, And so these are kind of the real world questions that I hope are enabled through this analysis. So this is the spreadsheet that brings it all together. It's actually the pivot table that's reading from this spreadsheet that brings the quarter century of data all together. This table that we're looking at, again, it's an eye chart, but it's looking at family medicine. We have a slicer here that's for family medicine. I can choose the specialty group that I want to look at, and I can use the clinical service area. It's called an NGS. It's the National Grouping System category that CIHI uses to describe things. So we're looking here at family physicians who do fractures. And then the set of indicators that we have here are participation rates is the first thing, but we have the years. And then what percentage of family physicians do this thing? When I look at everybody that does fractures, when I look at fractures, what percentage of providers does family physicians account for doing that thing? Because others do it, right? Like orthopedic surgeons do fractures, and general surgeons may do fractures, but family physicians do fractures, and we can get this breakdown. I'll give you some quick headlines here. In this time period, in this quarter century, back in 1996, 22% of family doctors did fractures. In the most recent year, 12%. So about proportionately reduction by about half of family physicians doing fractures. They, not surprisingly perhaps, represent a smaller proportion of all physicians that do that service. They accounted for about 3/4 of all physicians that did fractures back in 1996, and they account for about 2/3 of physicians that do fractures in the most recent year. Interestingly, their percentage of services is not reduced, although there's been some backing out, in terms of the percent that do it. They still do about 15 to 17%. In the most recent, back in 96, 15% of fractures were done by family physicians. In 2021, 17% were done by family physicians. Part of the reason is that there's more services per physician. These are all new indicators, right? Like you couldn't get this kind of indicator out of the CIHI data as it was. Back in 1996, there were about 4 fracture services per family physician. In 2021, it's about 7. So where you have people backing away from a service, there's an intensification of service among those that are kind of still in the game. A couple of other things, when we look at that service gap, I'm looking at the last column here, this column G. Family doctors are providing on a per capita basis as many fracture services as they ever did, slightly more actually. So even though there's been a retraction in terms of participation rates, the service is still there. And that middle column, that second to last column is giving what is paid to family doctors per fracture service. So this is kind of the intel that you can get from the thing. You can do this for everything, for 103 different things, right? This is just fractures. You can look at it for many, many different things. This is orthopedic surgery. It's the same set of variables. All I did was I switched to orthopedic surgery. The thing I would draw your attention to, just in terms of, it's interesting, we just saw sort of the reduced participation rate, slight reduction in accounting for the volume of service. Orthopedic surgeons are actually doing less fractures than they used to. It used to be 88% of them did it back in 1996, 82% in 2021. What I find fascinating here is the payment per service. So family doctors in 2021 paid about $260 per fracture service. Orthopedic surgeons about $551 for a fracture service. So it's a quick way to look at data and to just see what's happening with it. And with that, I'm not going to, I'm not going to say anything more about the data set, but we'll leave it to the opportunity later on to do a bit of a live demo to look at what some of this stuff is. So I hope that's okay, Bianca.
Perfect. Thank you so much, Steve, and virtual applause from us here virtually, and hopefully those in the audience. You should see those on Zoom that there is a poll question for those who might be in the room and have access to this Zoom account. Please go ahead and answer this poll. In the meantime, while that happens, Steve, just a couple of clarifying questions before we move on to Andy. One is that somebody was asking if you would be able to share a link to the database. Is that a possibility?
Yeah, I can share. I would like to say I can absolutely point you to the CIHI data for sure. We are working as a bit of a next step here to figure out how to plug this data. It is like right now it's a pivot chart in an Excel file, and that I have shared that around. But we're looking at how we can plug that in and working with with Chun, the host of today's of the conference, to just see if there's a way to sort of transform this into an interactive dashboard online, and people can just work with it themselves, So we're looking to a future that has that. So we're going to share it, Bianca, big time with the world. And in the meantime, I think the question is, how much do we share, of this actual worksheet? It's a bit of a beast itself. It's cumbersome, and it's still a bit of a piece of work in development. So yeah.
Sure. And then I know we'll certainly have a chance to have more meatier discussions later, but just one other question that came through that I think is a little bit of a clarifying question, which is that the billing data submitted by physicians may include work done by non-physician staff on their teams, like hearing tests done for audiologists. So can there be inferences about the quantity of services that are provided by non-physicians, although the billing is attributed to physicians?
Yeah, it's a good question. It's such a good point, right? Like if a physician assistant in a family practice does some cryotherapy, freezes something off or cuts something off, is that captured in this data? I do not know. I don't know. I can tell you that the data files that CIHI receives from medical service billing plans do not have provider codes for nurse practitioners or physician assistants. So if there is some activity that's happening, then it is getting billed through the accompanying physician, and I cannot quantify if that's happening at all, and if so, how much of it is happening.
All right. Well, thank you, Steve. Thanks again for your presentation. And Andy, we'll have you go ahead and pull up your slides. Andy Knapton is with the Graduate Medical Council in the UK. He'll be presenting on a UK medical dashboard.
I'll start with an apology. I've got a lovely cold, So normally I do presentations and people say, what the heck did he say? I've now got a head full of cold. So feel free to put in QA. Please try and say that in English again. But ho-hum, here we go. I'm going to talk about another big gorilla in the UK called the medics and their register. But first of all, I wear many hats. I have my own company called SMAP. I also work for the GMC. I also work for NHS England. I have also work for Shep Centre at UNC in North Carolina. I work for individual hospitals in the UK and professional bodies. So I have to give this disclaimer. Whatever I now say is from me. You contribute to me, not any of the ones I've just gone through. So make that clear. Andy said this. That's fine. The GMC did not say this. So I'm going to talk about the medical register in the UK and then get a live demo, fingers crossed, of the medical register. But quick bit of history. The first medical school in the UK was actually in Edinburgh in 1726. There was then a period, let's call it 100 years, when basically anyone could say, I'm a doctor. Which is probably why they created the medical register in 1859 to say you have to actually be approved doctor, which was a good idea because a year later there was someone on that list who was thrown out because they weren't a doctor. Interesting. Then we had in 1899 was the first case the doctor was struck off the list for drunkenness. So we still have that today. I'm not saying all doctors are drunks, but there is a review system now where you can be struck off and the whole system. So there's always a medical register is constantly being changed. You can on the medical register now, you can go to the GMC website, type it in and look for a doctor. So if you're seeing a doctor taking your kid to a pediatrician, you can type it. I think his name was Smith. Whole search. If I do a search for this doctor, and I'm quite happy to put this up because this is my daughter. And you can find out basically she's female and when she got full registration, which medical school she came from. And she's a GP, she's a registered GP, but she's registered without a license to practice. That means she's registered with the GMC, but she's not practicing medicine in the UK. She's actually practicing medicine in Australia. So from Ruth, I think it was earlier on, they're saying they're short of GPs. You've got one of ours. In fact, you've got one of mine. But you can also look at the data at the nearly the total level of the entire medical workforce. It is updated every night as people retire, as people come in. So you might come up and say to your boss, oh, the UK's got this number. And you come back the following day, it's a slightly different number. So it is live all the time. And it's nearly the entire. Some small groups are suppressed. So when we have age groups or certain slices, it disappears. So there is still very much an information governance awareness. Now, this is when I cross my fingers and hope everything works on the GMC website. If I can find the right link. No, I can't. There. So GMC website, let's launch the tool. That's a good start. And there's lots of breakdowns, and I'll just click on that. And here's the first visualization, hopefully coming up. So here is the entire medical register as it is across the whole UK. Pointing out the UK, we cover all of the UK. There's no worry about you're practicing Wales or England or Northern Ireland, Scotland. It's one medical register for the whole thing. You can work anywhere. And here's the net total number of things. So we've got, as of probably about 1 o'clock this morning, 37,230 doctors registered. And you can break it down by gender and have a split down through there. And we have GPs and specialists breakdown and the age profile down through there. So if you're interested in a particular area, how do we compare in the UK, in your patch, or maybe just, oh, this is a clever tool. How do they get the ideas for presenting the data? You can look at PMQ, which is primary medical qualification. That's our shorthand in the UK. Where did you train at medical school? And we typically aggregate it up by UK, EEA, that's just a complication of the EU, and everyone else, the rest of the world, and we call those IMGs. So you can see a breakdown here of the age group. So we have a lot of very young UK trained medical school doctors there. But as you get older, you can see there's more and more IMGs come in through here. So historically, and we still are reliant very much on the total. The health workforce is dependent on foreign doctors, and you can look at by postcode. So we can take the postcode of all doctors where they are working, not especially where they live, and it'll draw a pretty map of all doctors. Time passes. There. So that's everyone. And you can filter, you can put the boys and girls. I like this picture because it's almost exactly the same as, if I can find the picture, let's go back to here. This picture. It's remarkably similar, not France, but where there's light, there's doctors. Where there's no light, there's no people. So why would you have a doctor? Let's go to the right thing there. Then we can also look at revalidation. So in the UK, not only do you have to be registered to work with the GMC, to practice medicine in the GMC, you have to have an employer who says, yeah, I'm happy to employ them, and they revalidate. It's called a connection. So you can click on connections, and that will show the breakdown in groups of where people are working. So most of the doctors are working for an NHS body. Here, Deanery Let Bs, these are the training bodies. So doctors in postgraduate training, residents in US speak here. These are not connected. So that's a small, the 21,000 doctors, aka in there is my daughter, who is registered but not connected because she's practicing in Australia, and a 21,000 working in non-NHS. And if I click on, I can filter on that, click on an NHS, not double click, and you get a broken down. So unsurprisingly, of the 21,000 non-HS, 10,000 of them are working for locum agencies. So they don't have a physical area. They go where the locum agency and or vacancy is required. And again, you can filter by gender and PMQ and various attributes and years. Fitness to practice, one of the bigger roles, as well as registration and revalidation of doctors recording that. We publish data on complaints. So we can publish on that and just look at complaint summary. And so this will show over the years the level of complaints that we've received. Given that the number of doctors increased, number of complaints it's actually gone down relatively. And again, you can filter it and you can look at investigation outcome. So obviously, have the more recent ones, this red one here, 1600, is in progress. The latter ones, we've had an investigation, we've gone through, no actions or sanctions are being applied. So you can see a breakdown through here. So we used to have was that closed during investigation? That number is smaller, and these ones here is closed at triage. So the GMC has received it and went, this really isn't an issue for the GMC. But it's published, it's there, it's available, it's transparent. Finally, if I look at medical schools, we publish data on here. If I click on summary data. So here we have a breakdown historically in this bar chart of the doctors who are currently registered, the number from UK graduates. I have to stress that because I don't want anyone playing with this and going down here and say, there's no one here. There's a tiny number of people who were registered in 1997. That's because some of them have left at the point of qualification. Of UK graduates, how many are entered in the register, GP register? So that's the flows of doctors entering the GP workforce and the specialist workforce, typically the hospital base. Here's also the information about where they trained, and these are the geographic training bodies. And again, you can filter, and again, you can do it by gender, for example. And we have information on there. If I do current locations. So Steve in his presentation was raising lots of questions you could solve with the data. You could do this, could do this. This is pretty much a tool allowing you to, well, I didn't know we could do that. It's there, it's open, it's transparent, it's public to anyone and everyone to do what they like. So here I can show where UK graduates are practicing. Unsurprisingly, the big metropolitan area, London, has got the highest number of doctors, 23,000, and down through here. If I look at earlier on today, we had Alison talking from the UK and was saying about University of East Anglia. Where is it? Oh, come on, let's come. Talking about the shortage of GPs in Norwich. So these are graduates from East Anglia. So they've got Cambridge and Norwich. Norwich is right up there by my arrow, right at the top point there. So this shows that a whole chunk of graduates from that patch still work in that patch, and they're training and they're training delivering service throughout. And you can click on pretty much every medical school. If some of you've got sons, daughters, friends, relatives, you could sit there and say, oh, where are they likely to go? So if you're Humber, that's a very deprived area of England, and that was set up to address the workforce medical shortages in that area. But yes, a large chunk are in that area, but an awful lot they have scattered across the UK, which raises then queries about, well, does the idea of training in a certain area help, or actually putting into the greater good? Finally, I'll show distance from training. If I do from medical school, again, this is all that we very much research basis, the what ifs, discussions, it's there, it's published. So this is going to go a lovely heat map there. So this is a heat map showing the distance traveled from the medical school, that the doctor, a UK trained doctor, to where they're currently working across the whole UK. So whole of the UK, sorry. So 63,000 of everyone in the register travelled more than 100 miles from the medical school across the whole board. England appeared to do the most travelling, but everything's relative through there. But you can look at, I picked on, let's do Edinburgh. So Edinburgh, they typically go Edinburgh or Glasgow. This is testing my UK geography. That's Newcastle, that's Lancashire, Mersey, and that's London. So we've got an L9 database. It's there already. It's updated all the time about from there. That's pretty much my demo. I would welcome anyone with queries, questions. Oh, can you show me this? Come back. And it's totally public. Type in Data Explorer on the GMC website. Slides will be available. You can noodle and play as much as you like. This has just been updated 2 weeks ago into a new format. So any thoughts about, oh, that's rubbish, or that's brilliant, happy to be accepted.
Well, thank you so much, Andy. And again, virtual applause from us here online and from those, I'm sure, in the audience. And I actually did ask Sheena to create a little poll because I found the website myself and was able to play a little bit around. So we're going to pull up a poll, hopefully here, that just gives the audience some options of specialties that maybe you can queue up a little bit and talk a little bit about. So hopefully that will come up briefly soon. And hopefully we will get that website to folks because it is a very interesting and unique kind of opportunity to see all those detailed data that hopefully other countries can maybe replicate or just kind of get inspired by.
Just have to make sure when you Google it, it's GMC, and no, we don't mean the motor manufacturer.
Yes, thank you so much for pointing that out. Well, fantastic. I want to remind the audience, please use the Q&A function to help us queue up questions, and we will come back around to do some live demos based on the poll results that are coming through, and hopefully we'll have a little bit of time at the end for a little bit of Q&A additionally. Okay, poll is live. It's asking what specialty area you would like to learn more about. And this is a chance for Andy to go ahead and kind of queue up something to tell you a little story based on which specialty area you choose. I'll just give another moment here for people to respond to the poll.
I'm disappointed I can't vote.
I know. I noticed that too. I tried to click on something. I was like, oh, I don't get a choice.
Which one can I talk about? I'll click on that.
Maybe we'll ask you later, which one did you want to talk about relative to what was picked? Or maybe you can guess, what was the audience wanting to learn more about? So as people finish up that poll, I'll go ahead and start shifting over to our next speaker representing the US. We have Ben Stubbs. Ben is a research scientist with my center, the Center for Health Workforce Studies at University of Washington in Seattle. He'll be presenting today about the U.S. Workforce Dashboard on Commuting Patterns. So as you can see, the title of his slide already pulled up here. The focus will be shifted a little bit away from physicians and looking at a broader set of healthcare workers, the allied healthcare workforce, but still lots of very interesting data. So Ben, I'll let you go ahead, take it away.
Yeah, thank you for that introduction. And yeah, I'd say, this presentation is maybe going to look at a little more specific question than the previous two presentations. One of the things we think about with health workforce planning, of course, is where healthcare workers are needed and where they are working. But part of that equation is also where do they live, and how does that facilitate or make it more difficult to get to where they are working and where they are needed. So this presentation is about a dashboard that we developed to continue some work that we've done at the Center for Health Workforce Studies in Washington, at the University of Washington, looking at that question. So I'll start with a little bit of background. And as I mentioned, this is a question that people have been thinking about a lot for a long time. This is some work from Sue Skillman, a colleague at the University of Washington, looking all the way back to 1980 to 2004 in the United States, and looking at registered nurses who work in the same type of location that they live. So this is breaking it down by urbanicity. And so showing that, for example, if you look at the sort of orangish bars and the green bars, registered nurses who live in isolated small rural locations, as time passes, are less likely to work in those same location types. So looking a little bit more detail at those orange bars, where are those nurses that live in isolated small rural areas going for work? And you can see starting in about 1988, there's a big change where nurses living in those isolated small rural areas are going to small rural, large rural, or urban areas predominantly to work. Some additional work that was led by my colleague Arti Dahal here at the Center for Health Workforce Studies shows there may be some motivation for that trend to work in different locations. This graph shows on the x-axis the time of commute for several health workforce occupations compared to the average wages reported nationally in the United States for those occupations. So for many occupations, the longer they travel to get to work, the more money they are making. So there may be some motivation for those longer commutes, among other reasons for working far from where you live. So focusing a little more on Washington State, where I am located, this is some work we did relatively recently looking at medical assistants, comparing where they live to where they work. And if you look at the orange percentages that go across the middle of the screen. That shows medical assistants who live and work in the same geographic location as we defined by a grouping called accountable communities of health, which are healthcare planning regions. And showing that in some locations, medical assistants are less likely to live and work in the same location. And you can see where they are going compared to where they live. And then a final sort of historical example, looking at registered nurses in Washington state, again, showing geographically by county this time where nurses live and work, and showing the percentage for each county, the percentage of nurses who live and work in that same county. So that's some historical work that we've done in the Center for Health Workforce Studies, and I think relates to a workforce planning question that many people may have in various countries, trying to understand where workers live compared to where they work. But we were finding some sort of limitations to the information we were able to get using the data sources we had available. For example, this Washington state example that's on the screen now was done using primarily state licensing information. So registered nurses licensed was the state of Washington. And there can be some challenges with using that type of administrative data. For example, for registered nurses in Washington state, we're lucky we did, since 2018, the state licensing board has asked for nurses to provide information about where they live and where they work. But many of the licensing boards in Washington state for other occupations, such as medical assistants, that isn't information that they routinely collect. They potentially, and for many occupations, they only collect what is your home address, or where do you want your license sent, which may not even be the home address. So there's a little bit of a difficulty of understanding where do medical assistants live compared to where they work. So we were looking for other data sources to help us understand this information. And the data source we landed on is called the American Community Survey. This is a yearly survey administered by the United States Census Bureau. It samples about 3.5 million people in the United States, the District of Columbia, and Puerto Rico. And this is basically the survey that the Census Bureau conducts between or in the periods between the decennial census. But it asks more detailed information. For example, you can get information about education, employment, et cetera. Lots of good information there. Related to the question we're looking at today, it specifically asks about occupation using standard occupational classification codes, and also about geography, about where do you live and where do you work, as well as some other questions about commuting time, etc. But what we're focusing on is that basic information of where do you live and where do you work. And they aggregate that geographic information, or the geographic division that they use is something called a public use microdata area, or a PUMA. And these are geographic areas that each state designates, and there are requirements about how they create these geographic areas, including it should try to match existing geographic borders, such as state borders and county borders, as much as possible. It's meant to include about 100,000 people. So as you'll see, the size of these areas will vary based on the population of an area, as well as some other requirements. So using the American Community Survey, we created a dashboard, which I'll show some slides, screenshots of first, and then hopefully at the end all goes well and I can show a live demonstration. But we created a dashboard looking at all 50 states in the United States and the District of Columbia. We selected 15 occupations to compare where people live to where they work, or vice versa. You could look at it the other way too. We used a 5-year aggregation. So the American Community Survey is done every year, but the Census Bureau also provides files that are aggregates of 5 years of those surveys, and that allows us to look at more detail on these small geographic areas. And then we excluded the unemployed people who indicated they were working from home, or those living in an institution, so those living in like a prison or a medical institution. And so with that dashboard, we're able to ask some specific questions. So as I mentioned, one of the challenges we found using administrative data in Washington state is that it's sometimes hard to know where people live compared to where they work. And specifically, if they work outside of the state, just knowing where their mailing address or where they live doesn't necessarily give us information that helps us understand the supply question. So are there enough of a specific occupation working in a specific location, not necessarily just living there? And so one of the questions we looked at was cross-border commutes by certain occupations. So a little geographic orientation for those of you not familiar with the Pacific Northwest of the United States. There are several metropolitan areas that cross the state borders, and there are some examples here. Well, first, Seattle is located here, but then there's a metropolitan area that includes Vancouver, Washington, not to be confused with our neighbor to the north, Vancouver, British Columbia. But Vancouver, Washington, and Portland, Oregon are very close, and we suspect there's a lot of people who live in one place and work in the other. Another example is in the east of the state, Pullman, Washington, and Moscow, Idaho, and Spokane, Washington, and Coeur d'Alene. So these are areas where the metro area kind of spills across the arbitrarily created state borders, and so are people crossing those borders, and we may not be able to see that in some of the administrative data. And so looking at medical assistance, if you look at the dashboards, you can select medical assistance and the state of Washington, and this shows all of the medical assistants that were recorded in the survey and where they live. And so you can get a general idea of where medical assistants are living in the state, and it largely aligns with the higher populations areas, as Andy mentioned, Spokane here, Seattle area here, and some of the larger population areas in the southwest of the state. But looking specifically at our question of are people commuting across borders, if I select the medical assistant, the geographic areas here in the southwest of the state, near the Oregon border, near Portland, Oregon, and just look at those medical assistants, so select these areas, I see in the bottom of the dashboard where all of those medical assistants are working. And you can see it's a large area. So beyond just this question of cross-state commuting, we can look at generally where are people working compared to where they live. And at least for medical assistants who live in this area, you can see that some of them are commuting to relatively far distance. Looking at more detail, approximately 740 medical assistants live in the areas that I selected here. The one issue that we've had to understand and sort of deal with this data is that the geographic area that the Census Bureau defines as far as where people live is generally smaller than the geographic area that's in the data for where they work. And that's due to confidentiality concerns. They're trying to aggregate the work location to larger areas for confidentiality reasons. So when I go through the live demo, this will be a little more obvious, but what that basically means is that where people in this dashboard, the geographic region of where people live is not directly comparable to the geographic regions that are available to show where they work. So generally, where they work, the regions are larger. So specific to our question, approximately 36% of the medical assistants who live in this area near Oregon are estimated to work in Oregon. Another example on the eastern side of the state. So this is an example where the Pumas, the geographic region, they're designed to contain about 100,000 people. This area of the state is less densely populated, so the region that we're able to look at is very large. This is, in fact, a 6-county region in eastern Washington, but that's the geographic region, that's the smallest geographic region that we're able to look at that's related to this town of Pullman that we're interested in, which is about here. But then looking at where those medical assistants work, just to orient, this is the border of Washington and Idaho here. And you can see that there's a large geographic area where these medical assistants are shown to work. So that's what I mentioned about the Pumas being large. And in fact, the majority of medical assistants, at least based on this survey data, that live in this area in eastern Washington work across the border in Idaho, approximately 80%. So another example near Spokane, this area is more densely populated, so the areas where people live are a little bit smaller, the geographic areas that we're able to look at. And an estimated 7% of medical assistants live in the Spokane region, but work across the border in Idaho. So much smaller percentage than for some of the other areas that we looked at. So looking at registered nurses, another population we're interested in. This is the map of Washington State and where the registered nurses are shown to live. So again, looking at the area in Southwest near Vancouver, Washington, this shows that registered nurses that live in that area, some of them commute as far north as kind of the Seattle area, which is can be up to 3-hour drive to get that far. But then also some are shown to cross the border into Oregon, and some are shown to go even farther south to areas like Salem and Corvallis, Oregon. So potentially long commutes for registered nurses in this area. But similar to medical assistants, most registered nurses who live in this area work in that general area, in that same county at least. About 1%, as I mentioned, travel as far north as potentially Seattle, and about 40% work across the border in Oregon, related to our primary question here. Again, looking at the eastern part of the state, again, showing a large kind of footprint of where registered nurses work compared to where they live. Although 64% work in the same region that they live in, and about 20% work across the border in Idaho. And then finally, looking at Spokane area for registered nurses, you can see a very large work footprint here, with some nurses indicated to be working as far away as Alaska in the near Anchorage. So work footprint is really huge. It's a small number or percentage of nurses who are making these long commutes, but it does appear to be happening. And if we zoom in a little bit on Eastern Washington, the vast majority of registered nurses work in the same county that they live in. So looking at that, a few conclusions. Cross-border commuting is relatively common, but it varies. The amount of it varies by profession. We looked at 2 here. There are 13 other occupations in the dashboard that we could look at. And then also the degree of cross-border commuting varies based on the location that we looked at here. So relatively more cross-border commuting happening in 2 of the locations near Vancouver, Washington, and in southeastern Washington, compared with the area near Spokane and Coeur d'Alene, Idaho.
So Ben, I think unfortunately we've come to about time, so maybe we can find a way to incorporate the second part of the question as part of the live demo. But thank you so much. We really appreciate your presentation, Ben.
Yes,
and
thank
so,
you. Yeah, hopefully I can show some more in the live demo.
Yeah, thank you. So again, virtual applause from the audience here, and then from those from in person. And we do have a couple poll questions to help Ben set up the next part here. We'll pull up one that is about kind of picking your favorite geographic region to kind of focus in on. And then we'll have another one followed by which occupations, so that he can, or which occupational groups, so he can maybe set us up here. Oh, and I don't know what the third one is there. But hopefully you'll just
typo I couldn't undo.
Okay. So go ahead and queue up and help queue up Ben for this next part of the live round. In the meantime, I know Steve is there in person, so maybe he can start pulling up his slide from the choices that were provided. The choice that was of preference was to look at the family physicians' evolving scope of practice.
Yes. So I'm glad that you chose this particular one, sort of the family physicians' evolving scope of practice. Again, where you've got 103 different clinical service areas within multiple indicators, the participation rates, what % of family doctors do these things, what is their share of the volume of services, how many services per physician, and so on. So you can get at a lot of things. You can look at a lot of things. I'll say some things, we're going to look at a particular area, but things like mental health, individual and group psychotherapy, counseling, that's always been quite high for family physicians, is even higher now, and they account for more volume of service there. Hospital, you hear about hospitalist family physicians. Family physicians are as involved participation-wise, percentage doing it as they ever were over that quarter century that we have data for doing hospital-based inpatient assessments and so on. And they account for a similar sort of volume of services and similarly services per family physician. Obstetrical care, about a quarter century ago, about 1 in 4 family physicians did obstetrical deliveries. Now about 6% of them do them. And those that are still in the game do more of them. So there's evolving, this is all data that you can get out of this, data. What we're going to look at is these clinical procedures. So we've been looking, in my job, we look at outcomes of training. As family physicians complete their residency training, we ask them about everything that they had exposures to and everything that they intend to do, so interpartum care, palliative care, mental health care, chronic disease management, blah, 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 blah. We ask them, what about clinical procedures, whether they're done in your family practice or in a hospital? And this is an area where we consistently hear through surveys, family medicine residents saying, I didn't get enough of that in my training, and I don't think I'm going to do it. And it's mirrored in this data, this medical service data that we have. So here, this is a trend line. This is an endpoint. We're going to look at how this works within the dashboard I showed you earlier. But here's a number of things: fractures, allergy shots, incision of abscess, joint injections, removal of foreign body, suture of wounds, cryotherapy, excision of tumors, and so on. For every one of these areas that you can measure in that dashboard, when we look at the relative participation rates going down, more family doctors used to do that in 1990, well, in 2010, didn't use the whole time period here, but that's actually a good example. So we're going to take a look at how this works, and I'm hoping that this little video will work here. So we're just getting a live video of how this works. This was the screen when we looked at those fractures that we had. So now I'm just checking off. I'm saying, well, we only were looking at 2010, so I can very quickly choose just the years that were of interest, 2010 to 2021. So this is me just very quickly going through and selecting only the years that were of interest to us. The next thing is I'm saying, well, we didn't all I want to look at here is participation rates, volume of services per, blah, 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 blah. Let's get rid of all of that. So we get rid of all the indicators. And now we're down to just the one indicator, which is the participation rate. I'm leaving fractures in here because that was one of the things in our list, fractures. So we just leave fractures in as being one of the areas, but have to pick up some of the other things, those allergy shots, the suturing wounds, the doing cryotherapy and so on. So now I'm just looking at the drop down for the different types of clinical care. And I'm trying to remember in my brain what was the sort of the alphabetical order. I'm trying to remember whether or not cryotherapy is spelled CRY or CHRY and so on. So just selecting the areas of care that we wanted to look at. Fractures was already selected, so we're good there. But excision, there's excision of nail, excision of tumor. I said, well, you know, if you got a tumor, you probably want to get rid of that quickly. Incision or abscess. So just selecting the various things that were in that list there. And you can see actually, as we scroll through here, there are many other things. Some of them are they're not family doctor things, but they're things that if you were interested in general surgeons or orthopedic surgeons or you know, other medical specialists, you may want to look at these things. But these are all areas. So very quickly we get this is for all of them then. So we end with the participation rates for all of these things. That chart that we saw a moment ago with the downward lines, it's all based on this data here, actually. The last thing I will say about this, actually, you know, this may seem fairly arbitrary and random, and who cares really? But when you actually pause and think for a moment, a fracture, this is a bone broken in your body, and it's very painful, it hurts, and you want it to be fixed. So that family physicians have, you know, we go from whatever that number is, I think it was 14 down to 11% or something like that. I can't quite see it. It matters. Oh, there it is. Go, yeah, 14 down to 11%. Suturing wounds, removal of foreign body, like something is stuck in your body and it's foreign and it needs to be removed. It matters that you know, family physicians are doing that less. That's not a thing done. Suturing wounds, you're bleeding, and so you want to stop the bleeding. And you know, a removal, an excision of a tumor, like you have a tumor that's on you and you want to know whether or not it's cancer. And so that family doctors do these things really matter. So I know that it's just a list of things that we're looking at here, but I think in the real world, and that's what this data is about actually, it doesn't necessarily answer questions. I have to say that about it. It is not, so it is a way of exploring questions, and it often raises other questions. And that's the purpose of this data tool, right, is to allow us to explore questions and maybe get answers right here in the data, or to know at least where to look elsewhere for information. So that's a bit of the live demo there.
Great. Thank you so much, Steve, for showing us that little bit more extra information. So now we're going to move on to Andy, emergency medicine, one just a little bit out from geriatrics. So Andy, do you want to try to give us a go at what we can know about emergency medicine specialists?
How long have I got? Okay. Yeah. Right. Okay. So this is the total register, everyone on the board, and I can go to specialty here, and I can click in the wrong place. If I click there, I might improve and go. If I go emergency, there are lots of different ways of emergency. But if I can, I'll just select the first two guys. Come on, keep up. So that's an emergency medicine, and they've got emergency medicine with pediatrics. So there isn't an emergency medicine specialty. There's lots of different ways. One thing we do, slightly digressing, in the UK, if I click on the right tab, I'll move you out of the way. We have a published list of all the medical specialties. So if you train in the UK, you have to train under one of these, and there's a curriculum against each of them. So if you want to do emergency medicine, cunningly listed in alphabetical order, that is the curriculum. You can download the curriculum, and it tells you everything you need to do to complete your training. But there are many ways to get into emergency medicine if you didn't train in the UK. So if you're an IMG you can be an emergency medicine doc and come over into the UK as emergency medicine, but not as a trained one here, and you might come up with a different name. For example, in 2 or 3 years ago, we created the specialty of vascular surgery. That was basically a complication of general surgery, but we suddenly found a whole lot of IMGs who, I'm vascular surgery. Oh, yes, you are. But anyway, going back to emergency medicine, that is our profile of emergency medicine. I didn't stress this in my quick overview. This is, of course, a registered data. It is all by head count. As the regulator, it's not in our remit to say, are you doing half day a week or working 7 days, 24/7? That's not our remit. It's, are you registered? And you can look at it by gender, although it's there. So it's predominantly a male. Now, this is people in the specialty of emergency medicine. You can also, if I move that up, you can also look at and who is training in emergency medicine to see what your pipeline is. Tick, 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 tick. So if I go to training program, click there and emergency. So that is the breakdown of current emergency trainees in current number of trainees in emergency medicine. Now here, it appears like we dropped the number 2012, 2014, and suddenly went up. This is when you have to know the data. We reclassified how emergency medicine training was done. Previously, there was a core bit of training. We called it ACCS, and then you branched off into emergency medicine. Around about 2015, we made you to go. You could allow you to go into emergency medicine straight away. So they were ones who were in the first 2 or 3 years when they reclassified emergency medicine, which made it look as if we had more trainees. We didn't. We just reshuffled the pack. I have had to point people, don't write about expanding number of emergency medicine. It didn't exist. It's a data thing. Does that answer the query?
Yes, great. Yeah, Andy, thanks for giving us that kind of live show of how to kind of look at the data. And so the next up, we have Ben Stubbs, and we had these 2 questions, and I don't know if Sheena's able to show the results of that to the audience. All right, so San Francisco is a favorite. It gives you some temperature of the room of what's exciting to folks. And in terms of the area, it looks like some of the nursing professions is an area that we'd like to know more about, Ben. So do you want to try to take a look?
Sure. Yeah, let's see if we can explore that a little bit live here. Hopefully this all works. So I'm sharing, this is the web page where the dashboard is located. If I scroll down a little bit, I get to the dashboard. And we set it up so that initially you can look at the entire country, but then zoom into the area of interest. So I'll look at California and start out. Also, you can toggle between looking at where people live at the top and where they work on the bottom, or switch it and look at it in the other direction. So maybe I'll focus on, I'll look at advanced practice nurses, which since we looked at RNs a little bit previously. So this shows in all of California where advanced practice nurses are living according to the survey results from the American Community Survey. And if we look at the San Francisco area, we can sort of zoom in here and look in more detail. And I'm not super familiar with the specifics of San Francisco geography, so not. So I'll just select some of these areas that are around San Francisco, and say we want to look at Alameda County or Oakland, just east of San Francisco, advanced practice nurses who live there, and just select that one area, and then look at where they are working. And so this is the issue that I mentioned before, is that the workplace geographic areas are larger than where they live. So if I hover over this one, you can see this is the entire Alameda County, And you can see about 75% of the advanced practice nurses who live here in this section of Alameda County work in Alameda County, and then others commute to these areas here. So maybe select this area, Marin County, just north of San Francisco, another area where a lot of advanced practice nurses are shown to live, and then see where they work. And we can get information about that, again, looking at sort of larger areas. So as Steve mentioned, I look at this as kind of an exploratory tool. It may raise some more questions that it answers, but just to show the other side of the equation, let's look at where advanced practice nurses work, and then try to understand a little bit more information about where they live. So again, looking at California, zooming in a little bit on the San Francisco area. Again, let's see. So I think I moved a little too fast here. Let's select this area north of San Francisco, Marin County, and see where those nurses live. Primarily live in that same county, but there are some that are commuting from these surrounding areas. If I can, again, look at the Oakland area just east of the bay from San Francisco. So Alameda County, which contains Oakland. Let's see where those advanced practice nurses are coming from. And you can see that's a much larger area, some commuting from further south. So again, exploratory tool may raise some more questions. We do have some plans to update this data with more recent data, see if there have been changes, especially post-pandemic, and also hopefully add some more information that may help us answer questions like what are the demographics of these areas, so we can understand, like, are people commuting from an area that's maybe more affordable to live in to the central areas where there's more work, et cetera. So do have some plans to update this data and hopefully add some additional information that allows us to explore these questions in even more detail. So just want to point out one last thing. There are 15 occupations here that we can explore, and lots of geographic areas, and happy to share the link for this dashboard.
Great. Thank you so much, Ben, for that live show. And again, we'll try to get links out to folks so that you can all play and explore these dashboards yourself. And again, hopefully this serves as some kind of inspiration for your own country to think about what is possible with your data. So, just Ben mentioned some things that we're doing next with the commuting dashboard, and I'll just pose the kind of same question maybe to Steve and Andy is, what other data do you want to kind of incorporate here, or what's next when it comes to what these dashboards or data kind of dives are doing? So maybe Steve, I'll start with you.
Bianca.
Yeah, hear you.
I think like, because it is exploratory, right? And it raises questions. So what does it matter when family doctors aren't doing A, B, C, D, and E? I do think to bring this, if you wanted to understand that, to bring in other data sources, to look at community needs, where are there actual service gaps? We do have actually massive surveys going on right now with StatsCan looking at access to primary care and specialty care as well. And these are population surveys looking at access, looking at what happened in the clinic, what were your experiences, who did you see in that clinic? So I think that is a next step, actually, to just first get this out, get what answers you can get out of it. I think it will unto itself be sufficient in some cases. In other areas, it will raise questions, and to then start to triangulate the data to get a clearer picture. I think that's sort of the next thing to do, Bianca, is to sort of have this visualized, make it so everybody can go to a URL and play themselves, and then start to just sort of hopefully see some crowdsourcing and generative creativity around other data sources coming in to address those questions more fully.
Great. Andy, do you have any thoughts? I mean, it seems like a fairly fully formed data dashboard. So maybe there might be things that you want to see incorporated in here, or what might be behind the scenes about what's next.
Well, the main idea was that the number of us who are the get data requests, we had the same sort of stuff. How many emergency medicine? How many? It's like, well, yeah, it's dull. So we created this viz so that people can do it straight away. And I think some people believe, oh, then we don't need to have all these data analysts because it'll all done automatically. Fortunately, that's rubbish because people then use the viz and go, oh, I didn't know you know that. Can you? And the questions then become more complicated. Great for me, keeps me occupied. And if we get enough queries in this particular area, we add on the viz. So the first time was purely the registration information, and then we migrated to the geographics because more and more people are interested. Well, if I train them in here, are they working in here? No, here's the evidence. And I'm sure someone will look at it with a main beef. One of the spin-offs I've had from that is the question about, are we training doctors in the places we want them to work? So there are certain specialties which are in the UK massively skewed away from the general population. So from memory, like hematology, I think everyone has blood, but most of the trainees are in one geography, which makes no sense whatsoever because it's a very long way from London. Oh, did I say that? To the rest of the country.
Great. Well, thank you for that. Now, Ben, I'll turn to you. You talked about some challenges with some of the actual geographic differences in terms of what it means to work and live in different places. So kind of, I'm going to build off a question that Ivy Bourgeau kind of put here in the chat on our end, which is asking, what were some of the facilitators and challenges of getting the actual data into the dashboard? So less about the actual data itself, but the process that people might want to be aware of if they were to try to do this on their own.
Yeah, well, I guess one initial challenge was finding the data that could help us answer these questions. And we were lucky to find something that we could use. But then similar to what Steve was mentioning, the data come to you in this format that isn't necessarily exactly what you need to present the information that you're looking at. So there's a lot of work reformatting the data and selecting the variables that we were looking at, understanding how the data were collected. So I think that's a very important part. And Andy mentioned that with some of his visualizations. It looks like maybe there's a steep increase in the number of emergency medicine trained people, but you have to know kind of the information behind the data. So I think that first step of really trying to understand the data that we had, where it was coming from, how it was collected, and spending a lot of time kind of why are these geographic areas different, and why are the occupations coded the way they are, and what does it mean to be coded as a medical assistant in this survey compared to what you may see in licensing data. So things like that, just really digging into the data dictionary and really understanding what you're looking at.
Great, thank you. And Steve, I'm going to turn it back to you too, because you certainly are really fresh off trying to pull all this data together. So maybe you could talk a little bit about what helped as well as what kind of has made it difficult to pull it together, but also with the eye of now thinking, now that you have this data, what are the challenges that you foresee in terms of trying to communicate it out back to people?
Right. Thanks, Bianca. Yeah. The data's out there. It was like, I'm not, an IT expert or anything like that. I have pretty, old world skills. So basic, relational database skills. You can get a lot of data together. I do think, and I think, for instance, CIHI, the data set that I'm working with, they are interested and they may get the data further to an endpoint. I think plugging it in to the internet is important to have these interactive dashboards, what Ben and Andy have shown. Like that's sort of, I think, where we need to get with some of the data that we've been using. And who's going to do that, I think, is a big thing. Like I'm the College of Family Physicians of Canada. It's not really our job. I don't think we see it as our job to do that. So it is a question of who owns that work. And I think, so that is a bit of a challenge and a limitation. The last thing I would say on this, Bianca, is you start to look at the data, and I have looked at it at the level of provinces. You know, we looked at a Canada thing. People's minds are very quickly going to go to, well, that's interesting, but I'm here in Alberta or I'm in Quebec, and I'd like to know what it looks like for me, you know? And when you start getting down to that level, these indicators start to look weird. You know, like, because fee codes get delisted, they get reclassified in CIHI's National Grouping Systems category. Service counts can look odd, and sometimes it's a data quality issue. It's something that needs to be courteously brought, I think, to the attention of CIHI to do some fixes. Sometimes they reflect realities, you know, you know, examinations, like there are changes in what gets insured and what our public, you know, health system covers for people. So there's a legitimate changes that happen within medical service, and they become manifest in the data trends that we look at. So I think to keep an open mind and a curious mind as to what's behind these trends when we see extreme fluctuations and stuff like that, I think is going to be important to not become, you know, as we have greater access to data, to look at it in a constructive and collaborative and consultative way to understand, I think will move us forward better in terms of planning and you know, deciding around how to do medical services. Yeah.
Great. And I want to just double check if there are questions in the room. I know we only have a couple minutes left, but since I just can't see, I just want to check to make sure the in-person audience also has a chance to ask a question.
There is one question here, Bianca, that's
Could we
coming
ask
through
that
now.
person to introduce themselves as they
hi.
ask that question?
Sorry, it's Margaret Walton Roberts from Canadian Health Workforce Network. I had a question for Ben. I just wondered, Ben, if you're able to identify those who are living across the border, the international border. So I noticed Bellingham there, and I also think of places like San Diego.
Yeah, good question. No, unfortunately not with this data set. This is only a survey of US, and I don't believe they ask information about working across international borders. May not be as much of an issue, especially with licensing difficulties in international licensing issues. But with this data set, no, we're not able to examine that type of cross-border working.
Great. Well, I want to be cognizant of time. I know it's late in some countries across the world, and I know others probably have things to move on with their day, but there's also plenty of other sessions going on. We do want to encourage people to make sure they follow what's happening on social media. There are tweets happening for this still, or X's, or whatever we want to call it these days, but on social media, whatever, pick your favorite platform. We certainly want to make sure that folks outside of this audience today is aware of what's going on. I know everything's been recorded, so people can certainly you know, come back and listen to this later or share it with others. And I just want to check with Ivy, our fearless leader, to see if there's any other final things we want to say.
No, I think that's everything. We're going to have a 45-minute break now, just so that those of us here can have something to eat. And please do come back for our panel, which will be amazing on planning, and then a very, very rapid fire bunch of posters that we had people submit. So please do come back. So thanks, everybody.
And thank you to our panelists today for doing such wonderful presentations.